Welcome everyone to the ECG CRASH course. Today we're going to go through STEMIs and NSTEMIs and how to recognise this on an ECG. So firstly we're going to quickly recap coronary anatomy and the concept of myocardial territories. So the heart has two main coronary arteries that branch off from the aortic root. This is the right coronary artery and the left coronary artery. So this is an example of an angiogram of the left coronary artery. You can see the diagnostic catheter injecting contrast into the arteries to flash it up for us. So I'm just going to get my pen out so we can go through the specific branches of the left system. So the first part of the left coronary artery is the left main stem, which is this big trunk here. This splits into two main arteries that you need to know. The left anterior descending, also known as the LAD, and that goes all the way down to the apex of the heart. And this supplies the anterior myocardial territory. So LAD equals anterior myocardial territory. And it also has specific branches that you may be required to know. These are the septal branches and the diagonal branches. And there's an example of a diagonal there. And the diagonal supplies the anterolateral myocardial territory. The other branch of the left main stem is something called the circumflex artery, which is this one here. And this supplies the lateral myocardial territory because it wraps round laterally. It also has its own branches called obtuse marginals, and this is an example of an obtuse marginal here. And here is another obtuse marginal. So that's the left system. Here we have an example of a right coronary artery. So this is the beginning of it and it goes all the way down here. And it looks like a letter C, and that's the easiest way to recognise it on an angiogram. Things to be aware of the right coronary artery is it supplies the conduction system of the heart, specifically the sinoatrial node and the atrioventricular node, via its respective branches, which are literally called the sinoatrial nodal branch and the atrioventricular nodal branch. It also has other branches which you may be expected to know. This example shows a lovely acute marginal branch. And if we carry on distally down the vessel, we can see these two branches here. This one here is called the posterolateral branch, and this one is called the posterior descending artery, or the PDA. So the right coronary artery predominantly supplies the inferior wall of the heart, and it also supplies the posterior wall as well. Please be aware that the PDA branch can sometimes be found on the circumflex as well, in a left dominant system. So how does this relate to the ECG? Well, if we go back to our lead placements, we can see the precordial leads look at measurements of the anterior wall and the lateral wall as the leads are placed laterally. The limb leads look at the other myocardial territories, including the lateral and the inferior territories. So this is a diagram that visualizes it quite nicely. So if we focus on the precordial leads first, V1 to V4, we can see that they surround the heart anteriorly, and the LAD supplies the anterior wall. So if you see changes in V1, leads V1 to V4, that could suggest there's something going on with the anterior wall. If you look at leads V5, V6, ignoring 7, 8 and 9, which we'll look at later, V5, V6 and lead 1 and AVL look at the lateral aspect of the heart, which is where our circumflex lies. So these would be known as our lateral leads, and the L in AVL can be used as a cheating method to work out that it's lateral. Now if we look at our leads 2, AVF and leads 3, they look at the bottom of the heart. So they're known as our inferior leads, looking at our inferior myocardial territory. And the F in AVF can be remembered as foot, which is the inferior part of the body. So tying all that knowledge together to a 12-lead ECG, Our anterior leads are V1 to V4. Our leads V5 and V6, leads 1 and AVL are our lateral leads, and leads 2, 3 and AVF are our inferior leads. And here's a nice summary that you can take a picture of or keep in memory. It's just summarising all of that. So what part of the waveform in an ECG looks for myocardial ischemia? What should you be focusing on if our patient comes in with chest pain, for example? Well, the part that you're really interested in is this part here. This is called the ST segment. And the ST segment should always look flat like this, and it should lie on the isoelectric baseline, which is an imaginary line that goes through the ECG where the ST segment should lie on. Specifically the J point, which is this part of the ST segment right here, just at the end of the QRS. So that's a nice summary of what you should see. And if it doesn't look flat, that's when we have problems, suggestive of myocardial ischemia. So let's look at the concept of an ST elevation myocardial infarction. So if you draw our our isoelectric baseline in, we can already see that our J point, specifically our ST segment, is up in the roof. It's really elevated. So this is an ST elevation myocardial infarction. And that's suggestive of a total blockage of the heart, which is causing a transmural infarction. Now you might be asking, what's a transmural infarction? All that means is a full thickness myocardial infarction. So the full thickness of myocardium is basically dying, nicely represented by this diagram here. And that's, as I said earlier, a total blockage of one of the coronary arteries. So if you take this example, this is lead 3. So that's one of our inferior leads. So this is suggesting that the inferior myocardial territory is blocked or is dying, which is suggested that the right coronary artery is blocked. So here's an example of an angiogram, which you might see in the cath lab, showing a blockage. So we can see that there's a stump right there. And if we were to now pass a wire down that vessel and balloon that area, which effectively moves all the crap out of the way, we get this. And we can see that we've reperfused all of that inferior wall that was at that point in time dying. So let's now look at the concept of an NSTEMI, a non-ST elevation myocardial infarction, which, as the name suggests, is a myocardial infarction where you don't get any elevation. And this suggests a subendocardial infarct, which is not a full thickness infarct, but it's a partial infarct through the wall of the myocardium. So, and that's really suggestive of a tight stenosis rather than a full blockage. So findings that you'll see in an NSTEMI is classically an ST depression, which is when the J point, instead of lying on the isoelectric baseline, has moved downwards. Other findings that you might see for an NSTEMI are T-wave inversion and biphasic T-waves, which is when the T-wave looks like a sine wave. So here's an example of an NSTEMI. So if we look at the ECG methodologically, we can see P waves, a QRS and a T wave, followed by another P wave, QRS and a T wave. So we can say off the bat this is sinus rhythm. The QRS doesn't look particularly broad, so we know it's not a bundle branch block. And if we now analyse our STs and T waves, we can see this looks normal. So all of our anterior leads look normal. If we now look at our lateral leads, V5 and V6, we can see some T-wave inversion. If we now look at our other lateral leads, lead 1 and lead AVL, we can also see T-wave inversion here. Let's label that. That's not really good labeling. Idea. And then we can also see inversion in leads 1. So our lateral leads are clearly showing some myocardial ischemia, and our inferior leads don't particularly show any abnormal T waves. So we can say this is a lateral NSTEMI. And our lateral wall is supplied by the circumflex artery, and we can see a really tight stenosis there. It's as if someone's just gone in and pinched the artery. So that's just to put it into perspective, really. So please be aware you might see reciprocal changes. So reciprocal changes, I'll explain it to you now, is basically when you see a STEMI, for example, we can see massive ST elevation in leads 1, AVL, leads V1 to V4, even a bit in V5 there. So we can see a STEMI, most likely an anterolateral STEMI here. However, we can see ST depression, if we draw the isoelectric baseline here, in our inferior leads. Now, you might be thinking, does this show an NSTEMI and a STEMI at the same time? No, this is showing a STEMI with reciprocal changes in the inferior leads. And reciprocal changes are basically changes in leads where the infarct isn't happening. However, it interprets the electrical activity from other myocardial regions by showing basically the opposite pattern. In this case, there's a true infarct in the lateral leads and the anterior leads. However, the inferior leads are basically processing that injury as ST depression, because they don't directly look at that myocardial territory, if that makes sense. So we would just call that reciprocal changes. So if you were to summarize this ECG, you would say sinus tachycardia with an anterolateral STEMI with reciprocal changes in the inferior leads. So time to put your knowledge to practice. So we'll go through some examples now. Feel free to pause the video, work it out yourself, and then I'll show up the answer and we'll go through it. So a 56-year-old male presents to A&E with retrosternal chest pain. This is his ECG. Feel free to pause the video, work it out, and then the answer will pop up. So the answer is sinus rhythm with an anterior STEMI. The likely culprit is the LAD. So if you got that correct, well done. If you didn't, we'll go through it now. So you can see ST elevation in leads V1 to V4, a bit in V5, so you could argue that there's some lateral involvement, especially because there's also ST elevation in leads AVL as well, not so much in lead 1. So you could argue this could be an anterolateral STEMI as well. And then we have reciprocal changes in our inferior leads, which is why you see some ST depression there. I'll quickly draw in the isoelectric baseline just so you can visualize that nicely. There we go, and then we can see that ST depression going down there. And then we can clearly see the ST elevation, which looks like a tombstone in these examples here. So there's the ST elevation there. Good. Next question. A 73-year-old woman has collapsed outside of Tesco's. After 10 minutes of CPR, ROSC was successfully achieved. This is her current ECG from the ambulance crew. And for anyone who doesn't know what ROSC means, it means return of spontaneous circulation. So the answer is coming up in 3, 2, 1. So the answer is sinus rhythm with a lateral STEMI, ventricular ectopics. The likely culprit is the circumflex. So well done if you got that right. If not, we'll go through it now. So sinus rhythm, because we can see P waves, QRS, and a T wave that follow one after the other. There's no bundle branch block, and then immediately we can see some ST depression in leads V1, V2, V3, V4, but we can see some elevation in leads 1. I think this is the ECG's been cut off there, which is why it's not that clear, but this is lead 1, and we can see elevation in leads AVL, which are our lateral territories, and we can see some slight elevation in V6 as well, and not so much in V5, but there's definite lateral involvement here, so we can definitely say there's a lateral STEMI. If you don't know what a ventricular ectopic is, it's these beats here, which look a bit more broad, a bit more funny shaped. The ventricular ectopics are more explored in a different video called ventricular arrhythmias, so check that out if you haven't already. So yeah, well done if you got that correct. Don't worry if you didn't get it correct, you'll get better with practice. By the way, this ST depression here is the reciprocal changes we mentioned earlier. So the next question, an 81-year-old male who presented to the A&E for chest pain and feeling dizziness. This is his ECG. So the answer is going to come up in 3, 2, 1. So the answer is complete heart block with an inferior STEMI. The likely culprit is the right coronary artery. So again, if you don't know what complete heart block is, feel free to check out the video labelled AV blocks. It's explored more further there, but we'll quickly go through why it's a complete heart block here. So there's clear AV dissociation. You can see a P wave there, you can see a P wave at the end of the T wave, you can see a P wave there, a P wave there, a slight P wave there, a P wave there, and a P wave there. So each P wave is not followed by a QRS, so there's AV dissociation. There's bradycardia as well. I'd guess that the rate's probably around about 40 or 30 beats per minute. So AV dissociation, bradycardia, likely to be a complete heart block. And then if we look for ST changes, we can see right on the bat that there's inferior changes in leads 2, leads 3, and AVF there. And just to draw that out, we draw the isoelectric baseline here, and we can see that that J point is in the sky. And then looking at the other leads, we can see ST depression in leads AVL and leads 1 and AVL. If we draw the isoelectric baseline here, we can see that that J point is all the way in the floor. So, and then if we look at the other leads, from leads V1 to V6, we can also see ST depression. All of that ST depression are reciprocal changes. So a complete heart block with ST elevation in inferior leads, suggestive of an inferior STEMI with reciprocal changes in other leads. And this is the right coronary artery. So remember what I said earlier in the anatomy part of this lecture, that the right coronary artery gives off branches to the conduction system of the heart. If it's blocked, the sinoatrial node might not be working, and also the atrioventricular node might not be working. In this case, the AV node is not working, and that's why we have complete heart block. So next question. A 65-year-old male who's a known diabetic presents with epigastric pain, which sounds just like GORD. You decide to do an ECG just in case. This is his ECG. Feel free to pause the video, work it out yourself. Answer is going to come up in 3, 2, 1. So the answer is sinus tachycardia with an anterolateral STEMI. Likely culprit is the diagonal branch. So we can see a P wave there, a QRS, a T wave, P wave, QRS, T wave. The P waves are much more clear in lead 2. We can see that there. So we definitely know it's sinus. If you were to work out the rate, it is definitely sinus tachy. It looks visually sinus tachy. And then we can immediately off the bat see massive ST elevation in leads 1 and leads AVL. And we can see ST elevation in leads V2, V3, V4, V5, V6. So we have both anterior involvement and lateral involvement. So this is an anterolateral STEMI. We can see reciprocal changes in our inferior leads, which is why you get this ST depression. So you could say anterolateral STEMI with reciprocal changes in inferior leads. And remember when I said in the anatomy part of the lecture that our diagonal supplies our anterolateral myocardial territory, and that's why you see these ECG changes. So a word of caution and something to be aware of is diabetic patients typically present with atypical chest pain, which may be epigastric pain, which may mimic other conditions like GORD. So that could actually be an ACS that's hiding. So just keep an eye on that in the future as well, and when you're on placement. So next question. A 45-year-old gentleman with a strong family history of ischemic heart disease complains of chest pain, which occurred a few hours ago, which is now resolved. You decide to do an ECG just to check out what's going on. So this is his ECG. Feel free to pause the video, work it out yourself, or there's the answers coming up in 3, 2, 1, 0. So this is sinus rhythm with a Wellens type A pattern. The likely culprit is the LAD. So if you don't know what a Wellens pattern is, don't worry, we're going to go through it now. But if you said that there is biphasic T-wave changes in leads V1 to V3 and T-wave inversion in V4, well done. That's the finding that I wanted you to find in this example. There's also a cheeky ventricle ectopic there as well. Well done if you commented on that too. So what is Wellens pattern, or also known as Wellens syndrome? Well, Wellens syndrome is basically a specific ECG finding that you find if there's a really tight stenosis in the proximal left anterior descending, the LAD, that supplies the anterior myocardial territory. So there's not a blockage, but it's an extraordinarily tight lesion that will probably become blocked very soon. You get two patterns. So you get Wellens type A, which is this biphasic T wave, so it looks like a sine wave, or you can get a Wellens pattern type 2, type B I mean, which is this T wave inversion pattern. They predominantly occur in the ECG leads V2, V3 because they look at the anterior part of the heart. Obviously, as mentioned earlier, if you don't spot these, they may present as your STEMI patient later on, maybe a couple of hours or a day or two later. So always nice to pick them up. And these patients typically have chest pain that resolves and comes back and resolves and comes back. So just do an ECG in those patients. So just to put into perspective, here's a angiogram showing a Wellens syndrome. So left main stem, circumflex. This is the LAD in this angle. And we can see it's really, really, really tight stenosis. It's almost someone's pinched the coronary artery. So that, that's what's causing, the issues with the blood supply to the anterior wall. So next ECG, a 62-year-old female who presented to the A&E for chest pain and feeling dizzy. This is her ECG. Feel free to pause the video, work it out. So let's go through it. So well done if you spotted the ST depression in leads V2, V3, leads V1, so in the anterior leads, and you would not be scrutinized for calling it an anterior NSTEMI. However, if you ever see ST depression in leads V1, V2, V3, obviously without no other, ST elevation elsewhere, do a posterior, put posterior leads on. So you move your V4, V5, V6 to the back of the scapula and take a posterior ECG, and then you might see something different. So here's our ECG after we moved her leads, and we relabeled these as our reverse leads, V7, V8, V9, and we can see ST elevation in leads V5 and V6. So if you were to draw our isoelectric baseline here, you can see very, very, very subtle ST elevation, and you can see even more in this one here. You can see that's the J point's elevated up there, and you can see it also in V6, in V9. So this is suggesting a posterior myocardial infarction. Please, please, please don't miss posterior MIs out. If you see ST depression in leads V1, V2, V3, that might be reflecting a posterior infarct, because if we look here, the posterior wall is behind the anterior wall. So V1, V2, V3 can't directly see the posterior wall, but they might be showing changes that indirectly suggest that there's something going on there. So just move these leads there and you might see some elevation. So well done if you pick that up, but it's something worth knowing, definitely. So just a quick mention, how do you find out if your patient's had an old infarct or maybe an infarct recently? Well, there's certain ECG findings that can suggest that. The most famous one is a pathological Q wave, which are usually so that's the beginning of a QRS, the Q wave. These are usually deep. They usually can be greater than 2 millimeters or 25% of the QRS downwards, or they can be wide, so greater than one big box. You can also have poor R wave progression, and we'll cover what these two things are. So here's an example of Q waves in the inferior myocardial territory. So you can see that these are quite deep. This is practically 50% of the QRS, and you usually find them in the myocardial territory where there's been an injury. So in this case, these are inferior leads, so this is this is suggestive of an old inferior myocardial infarction. This is an example of poor R-wave progression. So normally, the electrical signal going from V1 to V6, the R wave, which is the spike upwards in a QRS, should progressively go more upwards. So it should go from here, it should slowly start pointing upwards, then more upwards, and then practically it should be fully upright. If the R wave doesn't progressively go upright from going from V1 to V6, that is poor R wave progression, and that is suggestive of an old myocardial infarction. Please be aware that if you see baby Q waves in leads 1, AVL, or V5, V6, those are perfectly normal. They're benign. They usually represent interventricular septal depolarization. So this might be a finding that's not suggestive of an old infarct. They're normal. So I think that's the end of the video. Thank you for listening. I hope you found it useful. Please check out my other videos on ECGs, and I'll catch you in the next one.